Okay, good morning, guys. Thank you so much for invitation to present about the mitral clip and to talk about our mitral clip program, now called Transcatheter Edge-to-Edge repair program. So I wanted to talk on behalf of the valve team. And I wanted to show what we do and what we can do and what are the indications for transcatheter edge-to-edge repair. My name is Simon. I think I know all of you. If someone on the line doesn't know me, I'm one of the interventional cardiologists here at Main Medical Center, part of the valve team, and I will be happy to present this topic to you guys. So number one, I wanted to say that the mitral valve, the prevalence of the disease increases with age. And when you look at it, people who are 65 above, about 6% of people have severe mitral valve disease. So that goes into millions. And when you think about the surgery for the mitral valve, it's only about 40,000–50,000 a year. So there is a huge unmet need for the treatment of mitral valve disease. And also what I wanted to mention is that the severity of the mitral valve regurgitation, it significantly matters. When you look at the severe MR and 2-year mortality, about 40–50%, that's not much different than bad cancers nowadays. The pathology of the mitral valve is quite complicated because we have primary and secondary MR. Primary MR, so-called structural MR, it's MR due to the prolapse of the flail, usually. These are the most two common pathologies, and the issue is the valve, and the issue is in the leaflets. When we have secondary MR, the issue is not the valve, the issue is the ventricle, usually dilated or ischemic cardiomyopathy, and it leads to the pulling and displacement, apical and lateral, of the papillary muscles that is causing tethering of the leaflets and lack of coaptation and the MR. Another group of patients has issue with the atria instead of the ventricle, and usually it happens in a setting of atrial fibrillation, and we have dilated atrium that is causing the leaflets to spread apart and lack of coaptation. So the etiology of the mitral valve disease is important because it matters. When you look at this graph, you can see that patients who have atrial mitral regurgitation, they do in between the other two. The worst are people who have sick ventricle, and it makes sense. If you have sick ventricle, even if you fix the valve, you are not really fixing the main problem, and these people do the worst. On the other hand, people who have primary MR, they do the best, and it also makes sense because the issue is just the valve. If you fix the valve, these people are doing the best. So what is the history of transcatheter edge-to-edge repair technology? It all started with Alfieri Stitch. He was a cardiac surgeon from Milan. He's actually still alive, and I'm not sure if he's practicing, but he was practicing recently. And he came up with the Alfieri Stitch. He started that in 1990. When he was doing open chest surgery, he was putting a stitch across A2 and P2 segment, across the middle of the mitral valve. And that's how he was treating the mitral regurgitation. So then it led to the patent that was submitted in 1997. And I guess many people don't know it, that the person who submitted the patent for transcatheter approach to Alfieri Stitch was Dr. Ross. The first procedure was done with the transcatheter edge-to-edge technology in 2003 in Venezuela. This is the patient that is still doing well until this day. Then it led to the trials like Everest-2 that led to the approval by FDA for primary MR of the clip. And then we had COAPT and MITRA-FR trial. It led to approval for secondary MR. And now we have new devices on the market like Pascal. I wanted briefly to mention Everest-2 study. It was the biggest at the time study in the mitral valve space. And it was randomizing people with who were undergoing treatment either with the clip or the surgery. 279 patients. It was a mixed bag of primary and secondary MR, and you can see that the clip was definitely safer, but was not as effective as the surgery at the time. But important to mention that it's a mixed bag of the primary and secondary MR. At the time, we didn't know better, and we were putting all of these patients in the same group. So it was followed by sub-analysis by Dr. Lim in prohibitive risk patients, and it showed dramatic improvement when you use clip in prohibitive risk patients, and it led to FDA approval in 2013 of clip for primary MR. Now we have 5 years data for Everest-2 study. We can see that there is a spread in effectiveness, but it's mostly driven by a very early period. So if people get a good result on a clip, they actually follow the trajectory of the patients that got the surgery. Also, it's very important to know that even though Everest-2 study showed that the clip was slightly less effective than surgery, there is no difference in mortality at 5 years. So the main difference is in the effectiveness, but not everyone wants to have the chest open. At the end, there is no difference in mortality. So it all led to FDA approval for the primary MR in 2013. Then in the guidelines, it was approved. And now the newest guidelines in 2020, they show that in primary MR, clip is approved for severely symptomatic patients with severe MR who have either high or prohibitive risk. So now it's a little bit loosened from prohibitive risk to high and prohibitive. So primary MR, any patient that is symptomatic and is high or prohibitive risk for the surgery, he can qualify for the clip as the treatment of the MR. Who are the patients who are high risk? So the patients are people who have STS higher than 8, who are frail, who have 1 or 2 organ systems that are failing. And this group now, all prohibitive risk, qualify for a clip in primary MR. So now let's shift the gears for a second to secondary MR. There was a COAPT study that was really greatly run by Greg Stone and that changed the landscape of the secondary MR. So that was the biggest randomized study in the mitral valve space at the time. It was 614 patients, and they were taking all of the people with the secondary MR. So again, people who have issue with the either ventricle or the atria that is dilated and is causing the leak on the mitral valve. And they were randomizing them either to the clip or clip plus so either to the optimal therapy or optimal therapy plus clip. And this is one of the most important slides. So who were they taking for the study? So number one, they were taking people who have moderate or severe MR. So 3+ and 4+ MR. People who are symptomatic, but you don't have to be extremely symptomatic. It's enough if you are New York Heart level 2. Also, you should be on much tolerated therapy. Your EF should be between 20 to 50%. Your LV cannot be extremely dilated. The cutoff is 7 centimeters for end systolic dimension. And also they were excluding people with RV dysfunction that would be super severe, or they would have really high pulmonary pressures. So most important, they were taking people with moderate to severe or severe MR who were symptomatic despite MARS therapy. We can see the primary outcome for the co-op trial, and there was a huge difference between people who got clip and who didn't. When we go to the mortality, it's even more significant or even more important. There was 17% decrease in mortality. Number needed to treat was 5.9. So when you compare it to any of the heart failure therapies that we know nowadays, usually the number needed to treat is in between 20 to 50. But in this case, you put a clip on the top of all of these heart failure therapies, and you have number needed to treat 5 to save 1 life. So that's extremely spectacular result. Nowadays, we have even 3 years data for co-op study. You can see that the curves are spreading even more. The number needed to treat is getting even better. Now it's 3.4. And also what is very interesting in this 3 years data that they presented, that they allowed the crossover. So if after 2 years, you were in a group that did not get a clip, but you were still meeting the co-op criteria, you could get a clip. And you can see that even at that time, if you get a clip, you follow the trajectory of people who got clipped, not the medical therapy alone. So the message is that even if it wasn't done very early, but you still meet the co-op criteria, then you can get a really good result. What else they showed in a co-op trial? So they showed a significant decrease in KCCQ summary score. They showed significant difference for the heart failure population. You can see decreased LVAD or heart transplant need at 12, 24, and 36 months. And now let's talk for a second about the other study. So when you read about the mitral regurg, the secondary one, at the time they published 2 studies. One was the co-opt, one was the mitral FR. And co-opt had this amazing results when, on the other hand, mitral FR didn't show that significant improvement. And there is tons of research why exactly it happened this way. And when they compared 2 studies, they realized that important is that it cannot be done all too late. So in mitral FR study, patients, they had less MR but more dilated ventricles. On the other hand, in co-op, they had more MR but less dilated ventricles. So the message is that the best is if you have as severe as possible MR with the LV in the best possible shape. And there was a bunch of other studies that were showing after that, that co-op-like population matters. So when you take people who are co-op-like, and co-op-like meaning all of this co-op criteria with the EF 2250, with severe MR on MARS tolerated therapy who are symptomatic. If you match into this criteria, you do significantly better after clip compared to people who are not co-op-like. And you can see that for all-cause death on the left side, or as well as for death or heart failure hospitalizations on the right side. So co-op trial changed the landscape of the secondary MR. It allowed FDA approval in 2019 for the clip in secondary MR. And in US guidelines, you can see that it has 2A indication for severe MR in co-op-like population. So again, people with EF 2250, with ventricles that are not crazy dilated, and who are symptomatic. Really important to mention that the surgery in secondary MR has a 2B indication, so has a lower indication than the clip. And it is very important because surgery shines in mitral regurgitation, but only in the primary MR. When you look at the lower diagram, you will see that people who have successful MVR, they follow the trajectory in life expectancy of general population, but it only and only applies to people with the primary MR. When you look at the secondary MR, people who got surgical mitral valve repair, after 2 years, 60% of them have failed repair and have moderate to severe MR. And it makes sense because if you fix the valve surgically, you don't keep the leaflets together. And if ventricle keeps dilating, this MR over time is getting worse. So one of the most important things is that for the secondary MR, for the clip, we don't even need the surgical evaluation because the clip has a higher indication than the surgery. So it's very different. When we talk about the primary MR, we can put clip only in people who are high or prohibitive risk. In people who are moderate or low, the surgery has higher indication, unless because of some reason patients are turned down. For the secondary MR, the clip in general has higher indication than the surgery. So this is the system that we are using nowadays, Mitra clip. You can see that we have 4 different clip systems, and they have different level of width and different level how long they are. And this combination of either the small one, NT, or the longer ones, HT, or the ones that have W at the end that are wide, is all for the best possible result. And nowadays, since last year, we have on the market this new device. It's called Pascal, new kid on the block. It's a little bit different design. It's from Edwards. It a little bit reminds the TAVR system from Edwards from the outside. And there are some major differences. One of it is the central spacer that doesn't exist on the Mitra clip. The other difference is that it can open into this diamond shape that allows us maybe to play more close to the commissures and decreases our chance of getting stuck in chords. As this device showed up FDA approved last year, recently there was a study published comparing Mitra clip device that we've been using for last multiple years compared to Pascal, and there is pretty much no difference. So these devices are very similar to each other. For now, Mitra clip was the only device. Now with Pascal, it will shake a little bit the market, and people will be using one or both devices. And here you can see, especially on this image, second to right, how it opens in this diamond shape that potentially can reduce the chance of getting stuck in a cord. So the mitral clip procedure, how it works, we get access on a venous side, then we go from the leg into the right atrium, then we do the transcatheter, we get to the left atrium, and then we advance the whole guide into the left atrium, and then through this guide we can advance the clip. Usually we do all of the positioning before crossing the valve. Then when we have best possible position, then we cross the valve, we open the clip, and we pull it back, and we try to grasp it in the best area that we believe will make the best reduction in the MR. Who are the best people for us to clip? So it's a complicated question because it's a scale. The easiest are people who have issue with the A2P2 segment, who have leaflets that are not heavily calcified, who don't have baseline high gradient, and their mitral valve area is large. Usually the cutoff is 4. Also important for us is the length of the posterior leaflet. but it's all a scale. So this is perfect patient, but most of our patients do not fit into this category, and we have to deal with people who are having leaps not across A to P2, or who have a little bit of calcium, or who have a slightly lower area than we wish to. So this is just showing the best patients, but truth is that many of the people that we do not fit into this category. What we know is that the result of the mitral clip matters. So if you leave patients with MR grade 1 or 2 at the end of the procedure, they do significantly better than if they have 3+ or 4+ MR. So if we end up with severe MR at the end of the procedure without significant reduction, these people follow trajectory of the people with medical therapy alone. So it's important for us to really get the best possible outcome. On the other hand, there is more and more data showing that the gradient does not matter that much at the end. The intuition says that if you put a clip, you create the stenosis, and then higher gradient you have, there will be more issues. But it is not yet that clear where is this line. In this study, they showed that if you have gradient of 7 at the end of the clip, it absolutely did not correlate with the hard outcomes after 24 months. In fact, in this study, they showed that people who had gradient of 3, they did worse than people who did 7. So it means that there was not correlation, but I'm sure there is at some number the line where people would in fact do worse. So for a second, I wanted to show a few slides from Expand G4 registry. That's a study run by Abbott, company that runs the mitral clip. It kind of shows what are the people who are getting the clip. Because many times there is a whole discussion how surgery does better, but it does not always compare apples to apples. Because usually people who undergo MVR, they have less comorbidities, they are more healthy, so also it is expected that they have better results. When you look at the age of the people getting clipped in the United States, so 77, so people usually are quite old. The STS score is 7.4. So that's a really high STS score compared to most of the people who get the surgery. High rate of the AFib, high rate of renal failure, diabetes, hypertension. Most of the people get 1 clip, although close to 40% end up with 2 clips. The results and the success rate is nowadays really high. So when you look at the implant rate is 97%, procedural success 97%, and we overall as a team we are getting better and better. So the device time now is 34 minutes and procedural time is 76 minutes on average. So it's becoming significantly shorter compared to what it was in the past. Also, you can see that there is dramatic reduction in MR, and there is less than 10% of people after clip who has severe MR, which is a really good result. Also, there is a significant difference in New York Heart class. There is significant difference in KCCQ scores, and also this procedure is quite safe. So when you look at all-cause death, MI, stroke, it's one of the safer procedures that we do, in fact, in the cath lab. Nowadays, there is more and more talk about new indications for the clip. One of them is cardiogenic shock. Often there are patients now in a hospital that we are consulted for clip in cardiogenic shock. It's a big interest recently of the research. And in this recent study in JACC, they showed that success of clip in cardiogenic shock was quite high, 85%. So not as high as 97 for elective cases, but quite high. The failure was 14.4%, And you can see on the right side that there is a significant impact of the clip. So if you successfully undergo this procedure, people actually have less mortality and readmissions. And number needed to treat, again, it's quite low, 4.8 and 6.4, which is really good. Then recently, I just wanted to mention those two studies that were published for a clip as the bridge to transplant. So we know that number of donors is not increasing, but the demand for the heart transplant is very high. So there is a high interest in therapies that could prolong life of those population. And CLIP is actually a very good solution in many of these people if they have severe MR. So in this registry, they were looking into people with severe heart failure, 3+4+ MR, who were candidates for the CLIP, and they were doing this registry in 17 centers. They were looking into people who are either active on the transplant list, who are waiting for clinical decision, or were not listed but were bridged to candidacy. And what is very interesting, so these people who were clipped, number one, 15.5% successfully underwent transplant, and it was 15% of patients who could be listed, and even more important is that 23.5% could be delisted. So 23.5% of the patients after a successful clip, they were able to be taken away from the transplant list, which is a great success. And then we have 2 years outcomes for the same registry, and we can see that 20% almost were successfully transplanted, 12.5% were listed, and 21% were taken away from the list, which again, it's a great success. So now I wanted briefly for 1 minute to mention our study that we just started. So there is a trial that we started in between the surgery and interventional cardiology. It's called primary trial, percutaneous or surgical repair in mitral valve prolapse and regurgitation for people who are 65 plus. It's a study that the aim is to evaluate long-term effectiveness and safety of TEER, Transcatheter Edge-to-Edge repair, compared to the surgery, and see how they do. So we will be looking for patients who have severe primary MR, and we will be randomizing them either to mitral valve repair or to TEER, and we will see how they do. Briefly, the inclusion criteria, we will be looking for people who are 65 plus, who have severe MR, and it's a severe primary MR, and have indication and meet the criteria for both the TEER and the surgery. And interesting part is that we will be looking for people of low, intermediate, and high risk. So not like the guidelines indication of only high risk. This study potentially is looking into changing this indication to intermediate, maybe intermediate and low risk group. So that's a great study with great institutions that are participating, and we are looking forward. So if you come across people with the primary MR, please think about us because we can evaluate for the trial. So at the end, I wanted to show a case that we did very much recently. It's a 66-year-old patient with CHF, with CAD, history of bypass, VT, flutter, ablation, patient with significant worsening of the shortness of breath on all of the good medications, and on echo found to have severe MR. So you can see on this TEE that patient had torrential MR, definitely in a severe category. And then we decided to take patient for a clip. So this is few images from the procedure. This is when we do the transseptal puncture, when we get to the left atrium. Then on the right side, you can see when we are crossing with the guide system, then advance the clip, and then we cross the valve. Here is the picture when we are grasping the leaflets. Here is how we see that on a 3D when we position the clip. And here is the result after clip number 1. And in that case, we had to add another clip number 2. And you can see the dramatic improvement. So here is before and here is after. So that's a great reduction. So if there is a surgical outcome, this is quite close to the surgical outcome for the mitral clip. So number 1, few conclusions that I also wanted to mention, and then I wanted to show the slide that we prepped for the office. So first, when you think about the MR, it's important to realize that there are these 2 different pathologies. So there is primary MR and secondary MR, and these are very different groups with very different treatment. The primary MR, the issue, the valve has to be fixed. Medications will not improve it. Patient has a problem with the valve that has to be addressed. And functional MR, the issue is the ventricle, and usually it's the heart failure, and the patient needs the treatment for the heart failure first. But then if it's not improving, we should consider clip. And patient does not need to be admitted to the hospital multiple times. Patient just have to be on the optimal medical therapy, and if it's symptomatic, one of the solutions is to send patient for the transcatheter clip placement. For primary MR, nowadays we have 2A indication for high and prohibitive risk patients. For secondary MR, we have 2A indication for COAPT-like patients. And we have 2 devices on the market. I wanted to finish with the inclusion criteria slide, but first I wanted to mention that our valve team, it's a big operation, and it's a lot of people involved that we work as the heart team. It's several of the doctors, and we are working all together as a team with all of our great Jess Weber and Debbie Courtney and Lisa Conway and Jeff Merrill, and it's a really close teamwork. It kind of reminds the heart failure work that there is impossible to make this kind of a job as a single person. It's a very very kind of close teamwork collaboration that we work all together. And I will have the pleasure to I wanted to say introduce, which doesn't make sense because everyone knows Debbie.
You know me.
So
Right.
I wanted to
Yeah, I just want to talk a little bit about how to refer your patients to the heart valve clinic. And so we try very hard to be available and to be very responsive. For outpatients, there is an outpatient order that you can use through Epic. It's an ambulatory referral to either MMC Heart Valve Clinic or MMP Heart Valve Clinic in Scarborough. And for you guys, it doesn't matter which order set you use. For us, it's a billing and a technical thing based on where we see the patient. But either order will get you a referral to the valve clinic. For inpatients, there is also an inpatient order to the valve team, but we're also in the hospital. Somebody is here Monday through Friday. For people outside of MMP Scarborough and Maine Medical Center, we are a consult service. So patients transferring in would transfer into the general cardiology service, and we would consult. We don't have primary care of patients here. We call patients who are outpatients within 7 days of receiving their referral. When we get them, we review all their records, we review their imaging. If their imaging is not here, we'll get it here and review it with one of our imaging cardiologists. We review what we think should be the plan of care. We tend to do testing up front and then a visit with the patient. For patients coming in through the outpatient pathway, we would want them to have a TEE before seeing the team. Sometimes we like to do that TEE, so it's fine if you're going to do one, but just kind of a word of caution that sometimes we end up repeating those TEEs because there are certain particular measurements we need to know if they have appropriate mitral clip anatomy. And we're happy to arrange TEEs and help with that. So a TEE and then a visit. We spend about 30 or 40 minutes on the phone with the patient and the family members when we introduce ourselves to just kind of go over what the referral is like, what the visit is like, what the process is like, and what a mitral clip is like. And then for inpatients, similarly, we see them while we're here at the hospital, in between cases on procedure days, and someone is always here. So you can reach us through Epic Chat, Epic Messaging, cell phones. There are multiple ways to reach us. So just feel free to reach out to us and we'll get back to you as soon as we can.
Deb, I have a question. This is Melissa Walters from Midcoast Cardiology.
Yeah, hi.
Hi. So with the TAVR patients, we'll typically have them get a cath ahead of time, but it just seems like with MR, there's so much nuance and a lot of these patients are pretty frail. Is it okay for them to go see you before something more invasive is done?
Yes.
Okay.
Yeah, typically the TEE is preferred if we're going to do something. We need the TEE because it gives us a lot of information to have a good starting conversation. But a lot of our patients come to clinic for MR with the TEE and no cath first. We'll send them off to cath afterwards.
Thank you.
Any other questions, guys? Like it's you can contact us again. I mean, we have fantastic team. I mean, with Lisa, with Debbie, with Jess, a few doctors on a team, and you can contact any one of us. So anyone that comes to your mind, you can send us the name and we will just, we will get back to you. One of us will get back to you with the feedback. You can, even if there is a patient that you are not sure if he would be a good candidate or, we are very happy. Like the clip is very different than TAVR. We get a lot of referrals that does not end up as a clip. Like many of these people end up as the medical therapy or gets to MPR, but it's all okay. Like number one, in a valve clinic, we see these patients usually we see all of them with the surgeons. So even though we had all of this discussion about the primary, secondary MR, truth is that we are structured the way that we just we have this great setup that all of us see people at the same time, and we are happy to see way more patients than actually waiting for this one perfect. So if you have any questions, just please send the patient our direction. We will be happy to look it up.
Yeah, this particular slide, this last one, Jess made copies that we can get out to folks. We had some sent over to Scarborough, but we can get them out to Midcoast and up to Main General to post in your office to just kind of remind you of the general criteria. We tend to follow the COAPT criteria and then just the coordinators' names and how to put the order in to just kind of be facilitate the process of referral.
Anything else? Any questions?
No, that sounds good, Simon. And then just one little, this is slightly off topic, but the TMVR, are we looking at doing that technology at Maine Med anytime soon?
Yes, I mean, that's a great question. Yes, we will. One of the issues is that TMVR, it's not yet that available as the clip, and usually it's part of the trials at this moment. And TMVR, it's even though it seems very attractive, for now it's quite complicated in a meaning that even when you look at all of these trials, you have some centers who've been screening people for the whole year to get like one patient for finally make it happen. So yes, this technology is improving. Yes, we will have it, and maybe even we will have it this year, but it will be quite a small niche on the beginning, especially of the patients that will be done with the TMVR. It's mitral valve is very different than aortic valve. It's way more complicated, and it's not that easy to find patients for TMVR.
Oh, can I clarify one thing though? The TAVR valve is FDA approved to put in the mitral space if the patient has a pre-existing bioprosthetic valve. So a previously surgically placed mitral valve, we can put a TAVR valve and do a TMVR that way. We have done a handful of those because those patients just really don't come along that often. The newer devices that are coming out for valve in MAC, in the de novo, in the patient's native valve to put a valve in there, those devices are sort of in the pipeline, they're coming. But we do TMVRs now if the patient has a previously surgically placed valve. And we have a patient currently who doesn't have appropriate anatomy, and that's kind of a big thing, is really all about looking at the CAT scan and the outflow tract and seeing if they're anatomically an appropriate patient to place that device. So it's a little bit of a fast evolving field and a moving target, but there is a particular indication for TMVR at the moment that we can do that's fully approved.
All right, excellent. Thank you.
All right, thank you so much, guys. Thank you for your time. We appreciate it.
Thanks, Simon. Thanks, Deb.
Thank you.